Welcome everybody to our newish edition of Call the Doctor. By definition, we're inviting you to call in to us if you have any questions regarding tonight's topic. Jean and I would like to invite our special guest tonight, Dr. Brantley, Dr. Julian Brantley, who has been serving this community since 1993. He could say something that not too many doctors can say, and that he's a fourth-generation physician that has served this area since 1889. That's very impressive. I don't know of another doc who says they have that heritage of service. So Dr. Brantley, why don't you tell us a little bit about yourself?
Well, I was born in Rocky Mount, and as you mentioned, my great-grandfather was born outside of Spring Hope, and actually decided he wanted to become a doctor and went to Jefferson Medical School.
My alma mater.
In the early 1860s, where he was a good friend of a doctor named Dr. Julian Chisholm, who was the Surgeon General of the Confederacy. Anyway, my grandfather came back and he settled back in Nash County and began practicing in 1889. He named his first son after his friend, Dr. Julian Chisholm, and his son was named Julian Chisholm Brantley, and he then went to Jefferson Medical School and came back and joined his father in 1917, and they were basically horse and buggy, and then they evolved into the carriage of the early, automobile stage of country doctor medicine. And then my father went to Jefferson and he practiced OB/GYN and came here in 1947. And then I graduated medical school and went into OB/GYN residency. Worked in Little Washington, North Carolina, and then came back here.
Did you break the Jefferson tradition? Or
I did. I went to the University of North Carolina.
There you go. Well, I'll make up for
Very
it.
good.
Jefferson's my alma mater.
So, and then came back here in 1993 to practice OB/GYN, and did that until probably 2005, where we decided to stop obstetrics. I practiced gynecologic surgery and kind of subspecialized in robotic surgery, and then stopped that in 2018, and since then I've been doing this sort of double job that I've evolved into.
Right. Let me introduce that to people. So he wears two hats. He works at the Nash Wound Care Center, which we'll explain to everybody what that does, but it basically is kind of self-explanatory. If you have a wound that just won't heal for whatever reason, and we'll talk about the reasons why people have wounds that just won't heal no matter what you try, you need to seek a specialist to employ new technology and sometimes even old technology to stimulate the wound to heal so that you don't end up losing a body part. Or have an open wound for the rest of your life and the chance of getting a horrible infection and potentially even dying from that infection. The other hat that the doc wears is he works at the Carolina Family Health Center and has done so since 2016. And we'll take some time in today's program to talk about that as well, how he helps promote the health of the less fortunate of our community. Right. So tell me a little bit about what a wound care center does.
Well, the Nash Wound Care Center was conceived and started in the early 2000s. A company was basically born that started doing that, and they used normal wound care procedures along with hyperbaric oxygen treatments.
We'll explain hyperbaric oxygen in a moment.
And that's part of what we do. And that company actually eventually evolved into leaving Rocky Mount. The hospital bought the company, and it became the Wound Care Center. And Dr. Stuart Todd sort of took the reins with that and did a wonderful job. They got a nurse manager named Wanda Sohn, who has been at the hospital there for 23 years and has been at the wound care center after working in the emergency room, been at the wound care center for probably 10 years or more. And they have developed this into a premier service for the community. It still allows hyperbaric oxygen and wound care that's provided by, I consider, a very excellent staff.
Yeah, I've known Wanda for 7 years now. It's truly an amazingly run institution. You've got some colleagues. Let's talk a little bit about them. There's Michael Crawford.
Yeah, we're very fortunate. Some wound care centers and other functions of the hospital have physicians that either have just moved to town or maybe less experienced. But the doctors that we have at the wound care center are extremely experienced.
Wonderfully talented.
Wonderfully talented. We have two general surgeons.
Doug Harrison.
Yes, Doug Harrison and Peter Muller.
Yep.
And they have both served our community for years, and they both work at the wound care center there.
Right. And Doug also works as a general surgeon in the hospital, an amazing surgeon. Yeah.
And then Mike Crawford is the medical director of the wound care center. He was a ear, nose, and throat surgeon and had a very successful career doing that. And he has done a superlative job of just continuing the excellence of that. And people don't realize it as much as, if you haven't ever been there, but it is a real asset for our community to have something like that. We're very fortunate.
Do most people come because they're referred by a doctor, or do they self-refer?
Both. They're referred by the hospital, by the emergency room, by other nursing homes, and
By myself.
and that's self-referrals.
Right.
I bet you see some people who are in a lot of pain that you're able to help, aren't you? I mean, people who just don't know there's help.
Exactly. We see some very, very significant wounds, and people come in thinking that there is no help, and they're given hope and a plan.
And we need people to pay attention to that too, because you might know somebody who's got a wound, and I think diabetes is often a cause of those wounds that won't heal. But if you do know somebody, there is help, and y'all do a great job there.
We also see a lot of what we call pressure wounds. People that have been in nursing homes or had severe illnesses and injuries, and they develop what was called bed sores of their lower extremities or their back. And we take care of those almost like they're something we see every day. And so we can devise a plan, and we can usually give these people hope.
Right, and the non-surgical management of these wounds is important, because you can often see a wound that's very big that goes way down into bone on their back, and then we could watch them slowly close over time with your guidance and with your intervention.
We use negative pressure systems, and they have to be coordinated with home health services, and we have an infectious disease specialist at the hospital now that has helped us with the institution of intravenous antibiotics that can be administered easily at home. And the combination of those two things has made a big difference in how our pressure ulcer patients do.
Let's backtrack a second and talk about the types of wounds and how we classify them, and then let's talk about the type of modalities that you have for very mild wounds to very large or deep wounds, because they are managed differently, correct?
That is correct.
Okay, so there's a classification system for wounds, and it's a simple classification system, but it does give us a sense of how we treat it, because we also have to appeal to the insurance companies for paying for this treatment as well. So teach us about the stages of wounds.
Well, we tend to initially evaluate the wounds in terms of their location and in terms of their etiology, their cause. And what we see is that we have a large number of lower extremity wounds that are caused by improperly functioning venous systems or a lack of arterial supply. There's just not enough blood supply to the leg. Or with diabetes, there's a nerve dysfunction and the patients really can't feel their legs or feel their feet, and they injure them repetitively and get ulcerations. And finally, we see patients that have, because of immobility, pressure ulcers, and they're sort of treated differently. But the pressure ulcers do have a staging system, and we manage them by stage, and we manage them by wound care, and we manage them with recommendations for offloading. And
So by offloading, you mean taking pressure off of a sore?
exactly.
Right. So let's say somebody comes to you with a diabetic foot. They can't feel the bottom of their foot, so they stand on it for hours at a time. And the blood flow at the bottom of that foot is shut off because of the pressure. But the patient has no feeling, so there's no nerve input to the brain saying, hey, Joe, get off my foot, right? And so because of the long period of time without oxygen flow to the foot, he starts to get a little ulcer on the bottom of it. And then it's ignored, or he doesn't know that he can do anything about it. And then he comes back to his family doctor 2 months later, and now there's a deep wound there. And the family doctor makes a referral to you.
Yes.
So now you have a wound that's the size of a quarter on the bottom of somebody's heel. It may or may not be infected. And so you say that you have to offload it. So does that mean that you create a special shoe for them so they can still put weight on it? Does it mean that you make them totally non-weight bearing? How much does that really affect the patient's lifestyle?
It does affect their lifestyle, but it's necessary for the healing, and that's the education that's involved with that is one of the things that we do. We have orthotic or they're businesses that specialize in making shoes for these situations, and they can measure your foot and see where the ulcer is and relieve the pressure where that ulcer is.
So you coordinate with other people in the community that can help us take pressure off of a sore.
We do. We communicate with the referring doctor to maintain good blood sugar control.
Important for a diabetic, obviously.
Very important. That's that tends to, poor diabetic control is associated with more infections.
What about protein levels for the elderly person who just doesn't eat enough? Many elderly people have a low protein level. I saw a person in the hospital in a consult tonight whose protein level is lower than normal. And that's adversely going to affect their healing. Wouldn't you agree?
Completely. And we encourage high protein intake. We encourage offloading. We encourage good diabetic control. We treat infections. We do cultures to monitor the infections, and we do debridements and appropriate wound dressings to
What's
include
that? Debridement.
debridements.
What's that?
It's to debride a wound is to remove the non-viable portions of it.
Okay.
So if there's dead skin or
Yes.
dead tissue around the wound, it's important to get rid of that. And why is that?
Well, on a small level, on a low level, we call it slough and biofilm. On a bigger level, you can call it just necrotic tissue. But bacteria live in that. And there are also chemicals that tend to impede wound healing that accumulate there. So to remove that on a regular basis accelerates wound healing without a doubt.
Wait, and you're talking about with the wound like an ulcer on a heel or something. If that were left untreated, it might be a mess to have a certain boot or something and take pressure off it, but it could lead to losing a foot, couldn't it?
Or a leg.
Or a leg.
Certainly.
So, I mean, and early intervention on these things is critical.
Oh, it absolutely is. The debridement part is very critical because the way that we fight infection in our body is our immune system attacks the bacteria. Our immune system also has white blood cells that will eat the bacteria, attack it, and specifically go for it. But they cannot go into dead tissue. They can only travel through the bloodstream and a little bit out of the bloodstream. And if there's a bacteria that's living in living tissue, then our white blood cells and other parts of our immune system can attack it. But if it's living in dead tissue, then it cannot attack it. Look at it as kind of like plaque on your teeth. Bacteria create the plaque on our teeth. They hide in that plaque on our teeth, and there's no way to get rid of it other than to scrape the plaque away with floss or with a dental tool.
Dr. Brantley, you mentioned lack of blood flow and whatnot as being a cause of wounds. How do you get more blood flow so that doesn't just come right back again?
It's difficult. One thing that I think has changed in the last 15 years is that vascular surgeons and radiologists, invasive radiologists have developed techniques of stenting and dilating and reestablishing blood flow to blood vessels, smaller blood vessels that have been occluded by cholesterol plaque and the things that basically stop up blood vessels. And so there is more hope now than there's ever been in the past that limbs can be salvaged. And it's stopping smoking is probably the first thing that a person can do.
Mandatory. Yeah.
We see that, or we know in the literature that when you do sensitive analysis of people's oxygen concentrations in their skin, that in their feet, when they smoke a cigarette, their oxygen levels in the skin of their feet decrease by 33%.
Wow.
And they stay there for an hour. So here we are bending over backwards trying to improve things, and we tell the patients, you can't be working against us by smoking a cigarette.
Right, and it's not necessarily the tar that your family doctor doesn't want you to take into your lungs. It's the nicotine that's in the cigarette that doesn't necessarily cause cancer, but the half-life of nicotine is 12 hours. So if you have one cigarette, that nicotine is in your system for 2 full days. And so if you chain smoke, or even if you smoke 4 cigarettes a day, the amount of nicotine that you bring in your body can really tremendously hurt all efforts that we make to heal a wound. You had sent me a patient a month ago on a fellow who had an ulcer in his lower back, and it was not healing. Well, it healed wonderfully, but it got to a point where it just needs to be closed surgically. And the way that we do that is to take some of the muscles from his bottom, his buttocks, and move that into the wound, and then skin graft on top of that. It's a big surgery. And the surgery still hasn't occurred yet because it refuses to do 2 things: stop smoking and buy a bed that will allow him to offload it. So,
We need to take a break.
okay, it's time for a break. So we're going to talk more about Dr. Brantley's wound care and then evolve that conversation into his benevolent care into the community when we can see you back on the other side.
Thank you.
What is the Davis Furniture difference? The difference is we buy with you in mind. For generations, we have listened to our customers. We can help you find the look you want for every room in your house. Quality, style, color, and of course, service. Follow us on Facebook and Instagram. Davis Furniture, the family business where we treat you like family. Let us help you make your house a home. Davis Furniture, historical downtown Rocky Mount, on the corner of Hill and Main.
Being prepared and trained is the best way to keep your family safe. The best way to be prepared is to learn from those who've spent a lifetime protecting us. Barnes Safety and Consulting LLC offers concealed carry classes with instructors who are law enforcement officers active and retired with more than 100 years of law enforcement experience. Monthly classes are taught year-round with private classes and special group rates available. Classes are $75 and held in the Bailey area. Call or text 1-800-653-0643. Get your concealed carry permit and avoid becoming a victim.
Experience Christmas at John's Gifts and Furniture. Decorations, wreaths, trees, Christmas candles, lanterns, and fragrances. And if you want to make your mantle beautiful for the season, John's friendly staff can show you how. Don't forget to order your Christmas bows now. Everything designed in-house. We have many great collectibles such as Buyer's Choice Carolers, Karen Didion, and Christopher Radko. Visit our new addition, John's Boutique, where you will find great designers such as Clara Sunwoo, Frank Lyman, Tyler Bow, and Consuelos and Hobo Bags. And ladies, check out our beautiful designer jewelry by John Medeiros, Susan Shaw, and Julie Voss. John's Gifts and Furniture, family owned and operated. We can decorate your house, and we can decorate you.
Welcome back for our second half of Call the Doctor. Please feel free to call in at the number that we'll put at the bottom with any of your questions for Dr. Brantley regarding the WUCAN Center or what we're going to talk about in a minute. But before we talk about the community health programs that you participate in, I would like to get some more information about Hyperbaric because you mentioned it a little bit earlier. First, I'd like to point out that we are absolutely blessed that we have such advanced technology at Nash, right? Nash's administrative coordination and the input that they provide to us in supporting truly a state-of-the-art wound care center. I've worked at multiple hospitals through my 25 years, and I honestly have never been to any wound care center that is as advanced as the one at Nash. There's one in Wilson, can't hold a candle to this. There's none in Edgecombe. And really, this is just a premier institution. And one of the things that you hinted to was hyperbaric oxygen. That's a device that helps us optimize the oxygen levels in the tissues. Explain that a little bit to us, and then we'll if there's no questions on that, then we'll start talking about the other hat that you wear.
Well, hyperbaric oxygen has been, it's a modality that has unequivocal benefits for certain diseases and equivocal benefits for others.
Meaning it's darn good for some and okay for others.
Yeah.
Yeah.
It delivers oxygen, and we think of it as oxygen as a drug. It delivers oxygen in massive quantities to the serum, which then circulates to the blood that circulates in the body. Now, most oxygen is carried in the red blood cells, but some is carried in the fluid of the blood itself. Not all of it is in the red blood cells. And so what we affect is the oxygen that's in the fluid of the blood. And we drive the level. We will take, for instance, now I don't want to get too specific, but just for everybody out there, the atmospheric pressure that we live under is 760 millibars of mercury. So what we do is that we double that. We put patients in a chamber and increase the pressure so that rather than 760, it's twice 760.
Their whole body, they sit in something?
It's the equivalent of being under 33 feet of water.
Whoa, okay.
But instead of breathing room air, we pump in 100% oxygen. So what that does, and without going through the calculations, it takes, it basically increases the oxygen that's in the fluid part of your blood. It increases that level by 10 or 15 times.
You breathe it in, and then it goes into your vascular system, and that's how it increases.
Yes.
Because I pictured putting your foot in there and having that
No,
bombarded with something.
your whole body is inside of a tank.
Uh-huh.
So that your internal oxygen level is just is literally 10 times what it was. We're careful. In there are medical precautions that you have to take when you get under that pressure and give that much oxygen. We're aware of those, and we do it very carefully. But what the patient is getting is this massive, large dose of oxygen, which improves healing and it decreases infection. It unequivocally is the treatment for radiation-induced hemorrhagic cystitis. So people men who've had radiation treatment for prostate cancer and develop blood in the urine from radiation-induced cystitis, we can treat that with hyperbaric oxygen very successfully. And we have patients that are referred from Greenville. We have patients that are referred from all of Eastern North Carolina to our wound care center for that. Another condition that's unequivocally benefited by this is what they call osteoradionecrosis, where people have had head and neck radiation, usually for head and neck cancers, and they develop problems in their jaw. And they sometimes will have to have their teeth removed, but they end up with infections in their jaw. Well, the treatment for that is hyperbaric oxygen. And we have patients, once again, from all over Eastern North Carolina, from oral surgeons and dentists in Greenville and everywhere. So we're very fortunate to have two, what we call monoplace, where one patient is in one chamber, hyperbaric oxygen chambers here in Nash County.
We really are. That was really interesting. I had no idea.
An impressively high-tech institution we run here. Yeah.
Thank you for doing that, Dr. Brantley. I hope I never need it, but I mean, I'm really glad to know we have it locally. I've heard of people with like a foot wound who've ended up using the hyperbaric chamber.
We use hyperbaric oxygen for diabetic foot ulcers at certain stages. So we try to blend that with the other therapies, and if that's beneficial, we usually can find a way to make it work for the patient.
I want to have you say one more time, if people have a wound, if they've got a family member with a wound, a friend with a wound, how important is it to get help sooner rather than later?
It's very important for two reasons. First of all, the wound itself is a problem. And secondly, the wound can be a symptom of a deeper problem. And so you want it evaluated. And that's what we ended up doing. Very often we'll find patients that come in with a leg wound or something, and actually they have more of a systemic illness than you would have ever thought. And with the right referrals, we can usually get to the bottom of the problem.
Wonderful.
And save them from a whole lifelong of misery.
Exactly.
Absolutely. You wear a second hat.
I do.
Let's talk about that.
Well, in 2018, and the practice that I was involved with stopped functioning as a solo practice, or as a group practice. And I was aware of and contacted by the Carolina Family Health Center group, which is a rural health group centered in Wilson. They have a clinic there in Wilson and one in Freedom Hill outside of Princeville, and they have one on Highway 58 near Elm City between Nashville and Wilson. It's called the Harvest Clinic. And they have 17 to 18 providers in those clinics. and they needed somebody to help them with their referrals for abnormal pap smears. And there were a lot of them, and they had gynecologic problems that needed gynecologic referrals. These patients were often self-pay, and so they would make the referrals, but the doctors, the offices that they were referred to, demanded some type of upfront payment, which I can understand, but they couldn't pay it, and so then they never followed through with their referral, and so what we ended up doing was constructing a system where we had internal referrals. And so I went there 2 days a week, and so anybody that needed a GYN referral would just come to me, and we could do the colposcopies, we could do the LEAP procedures, which are a treatment for cervical pre-invasive disease. We can do DNCs, and we have access, because of a federally funded pharmacy, to some fairly good prices for some drugs that can help patients who have problems with abnormal bleeding. And so we've been able to sort of construct a gynecology referral service in this group of people that probably 60% of them or 70% of them are self-pay. So, you know, whereas some people would say or think that Medicaid or Medicare patients were not very financially well off, in our world, they're the best. We think that somebody has Medicaid or Medicare, we think they have insurance. We probably 70% of our patients don't have, or self-pay patients, they don't have anything, and yet we find a way to see hundreds and hundreds and hundreds of them every week and keep the ball rolling.
And it's a sliding fee schedule. I mean, if somebody can't pay, then you all find a way to provide the treatment they need anyway, right?
That's correct.
But nobody's denied any care.
That's correct.
What about, now, Harvest? Where did the Harvest come from?
Well, that was the original name for the clinic, and I was told that some Catholic nuns initiated that clinic decades ago, and it existed out of a couple of old trailers, and it was subsequently taken over by the Nash County Health Department. And then subsequently, then it was, the ownership of it was transferred to the Carolina Family Group, and they were able to find the grants and the funds to build a nicer clinic, and it exists now like that. But what we find, and people wouldn't, you know, unless you work there, you wouldn't know it, probably, you know, 33% of our employees are bilingual.
And need to be, right? Because a lot of the patients don't speak English.
And we have interpreters at all levels of where we work.
Good.
So that if I have a patient who doesn't speak English, I have an interpreter in there along with a nurse. So it still slows things down a little bit, but they're still possible. You know.
I've known you a long time, and I really want to point out that I can tell this means a whole lot to you to be practicing this type of medicine. I mean, it seems like it's really, having done what you've done up to this point, that it brings you great joy to know that you're ministering, in essence, to people who couldn't get care otherwise.
That's the truth. Most of them could not get care. And, you know, I'm especially thankful and proud of some of the situations that have developed in Eastern North Carolina. There's a doctor who's moved to Greenville, and I'll go ahead and mention his name. It's not Dr. Granger Leno, who is a GYN oncologist, and he has reached out to me and said, please send me your patients, we'll take care of them. And we have probably more than we should patients that show up and they have GYN cancers because they've had problems for years and they just haven't been attended. And so after working them up and diagnosing the problem, he has been a source of referral and very responsive the surgery is very advanced, robotic surgery, and he sends them back, and the patients are taken care of, and I'm proud of that. I mean, we've done good work for a lot of people.
Yeah, and the Harvest Clinic refers not just for GYN as well.
Oh, it's a primary care facility. One interesting thing is that Dr. Peter Muller, who works at the Wound Care Center, also works at the Harvest Group 4 days a month, and basically he does all their minor surgery. So if someone comes in with a large lump or something that needs to be excised, he'll do it for them. And he does that one day a week. So, you know, we've got at the Harvest Clinic, and I don't know what it's like elsewhere, but that group in Wilson takes care. They have a Ryan White program, which is the federally funded program that provides care for HIV positive people. They have over 550 patients enrolled in their Ryan White program in Wilson, North Carolina. And the most of them are from Nash and Edgecombe County.
I remember when I worked at Almonds Drugs, we filled a lot of those prescriptions, and they always came from that clinic, because that seems to be the real go-to place and support place for people in need of that care. It's something to be proud of.
What about our population that does not get mammograms? Is that a service that's offered? Because that's something that's often ignored by many women, be they insured or not. An underserved population tends to ignore mammograms even more, and so the diagnosis of breast cancer can be delayed in that population. How do we manage breast cancer?
At the Harvest Clinic, or the Carolina Family, what we do is that we do rigorous evaluation of our own performance to make sure that every patient at a certain age group gets a mammogram at an appropriate interval. So it might be every other year up to age of 50 and every year after that. And we've got 3 or 4 different ways to do that. The University of North Carolina at Rex Hospital sends a bus down, and they will take our uninsured patients and give them mammograms. So once a month, the Rex bus will show up at these different sites, and the patients line up and get their mammograms. Of course, Medicare and Medicaid do reimburse for mammograms, so they can get their mammograms either at Nash or at Wilson. And finally, Wilson Community, which I want to take my hat off to them, they have a community program that provides free mammogram service for it's a limited number, but it's a big number. And we can basically, for patients who are from Wilson County, who are unable to pay for their mammograms, they have a fund that funds mammograms for them. So between all of that, we usually can get mammogram services for all our patients.
Do each of the locations cover all the bases, or might somebody like from Freedom Hill have to go to Elm City to get some specialty covered?
No, they're all
basics everywhere. Great.
They're all the same. All the same. I go to all 3 clinics. Well, actually, I don't go to Freedom Hill anymore, but so I guess, but there is a doctor there that does some of what I do, and then she sends me what she doesn't feel comfortable doing. But yeah, all 3 clinics are pretty much the same. Now, the Ryan White program is predominantly in Wilson, but it does have a Freedom Hill and a Harvest appendage.
What about more sophisticated things? I know you mentioned your physician friend in Greenville. If there are other things like appendectomies and things like that, I know you mentioned that Dr. Muller will do some of that 4 days a month, but what about the rest of it? Are there places to which you can refer them?
No.
Well, there is for orthopedics. I get plenty of referrals for orthopedics.
We struggle with referrals.
Uh-huh.
And we unfortunately, we have to use the emergency room a lot. And it depends on whether the patient has Medicare, Medicaid, or some commercial insurance. But the self-pay patients, we struggle with that, and sometimes we're successful with referrals and sometimes we're not.
What are the age ranges, Dr. Brantley, of people you see?
I generally don't see adolescents, but I will. And I see patients right on, if they have GYN problems, right on, there's no age limit. I don't do surgery, so basically all the therapies that we do are non-surgical, but if it comes to needing surgery, we have alternatives where we can send them, for instance, to Dr. Leno, and he'll help us. We go by protocols that are pretty standard in terms of adolescence and pap smear surveillance, and a lot has changed with pap smears, and so it's a little bit, I think we're up to date with all of it.
What do children do? Where do they go?
Well, we have pediatricians in that group, and we have, of course, family practitioners and nurse practitioners, but we also have practitioners that specialize in pediatrics, and so we do a lot of full pediatric service and all the vaccinations. Of course, we had a very active COVID vaccination program.
Are you going to be offering them to the 5 to 11-year-olds too, do you think? The younger kids?
I'm sure. Yeah.
Good.
What challenges do you see in growing the program, or or making people aware that the services exist?
With the Harvest
Yes,
group,
do you have outreach? Do you go through churches? Is it word of mouth?
no, it's there, and I think what we want to do is to preserve it. It's not so much to grow it as it is to preserve it, and keep it quality, keep it what it is. It's Nash, Edgecombe, Wilson County, and right now that's what we want to do. We want to keep it. We want to make it as good as it can get.
Do you still find that a lot of migrant workers who are coming for farming in this area use that for service?
It's unbelievable. The number of patients that we see that are in that that patient type, people don't understand how large that population is.
And how needed they are in our community to provide that segment of labor.
It's impressive.
They're a wonderful group of people, sometimes I think I say, how bad could it have been for them to pick up their family, leave where they were, come halfway across the continent, and settle in a small eastern North Carolina county, not speaking English.
With nothing but uncertainties in their life.
Yeah.
Right.
How bad was it? And what, and I don't think we understand how bad it must have been for them to be motivated to be here. And I think a lot of it, these patients, a lot of them have a strong family the strong family ties. A lot of them are Catholics, and they're very devout. And I find that they're very, very. We're lucky to have them in some respects. If you understand what I'm saying, I think they're fine people.
And hence the Catholic nuns who started with 2 trailers, in essence, to provide for many of the people they saw in their church who were completely not devoid of any health care to support them.
I can tell you, I can't tell you the number of patients and situations I've seen where people literally, started crying out of thankfulness just that somebody took care of them.
Several of our pharmacists left. Merritt Roan, you might know her, and Holly, what was Holly's last
Gentry.
name? Gentry. And they love it. They both worked at Almonds, but they, kind of like you, their heart was that we want to help in underserved areas.
It's interesting that the CEO was a lady named Dee Johnson, and she slowly built that organization up one little piece at a time. And now a woman named Laura Owens, who's a pharmacist, is a CEO, and she's done an absolutely wonderful job. The chief medical officer is a doctor named Abraham Chaparro, who of course is bilingual. He was from Columbia. I mean, very, very energetic, compassionate, and bright. I can't tell you how impressed I am with the people over there. So I'm glad to be there.
And it's a very valuable service. I've seen by my overseas mission work the reasons why people pack up their families and walk 2,000 miles. It's like us walking from here to Phoenix across the Rockies with no possessions and with babies roped to our backs and often without any food guaranteed for the next day. And all the patients that I've treated in Honduras and Ecuador and other countries are absolutely wonderful, beautiful people. And those are the same people that I see here in my practice that I treat here. And it's a shame that our society denigrates them as to some automatic criminal when they're not really the criminal. They're often the victims of criminality, and they're doing the same things that we would do if we were in their situation, just looking for a better life. And that's why our parents and our grandparents came here. And so you treat them with that respect, and that's a very nice thing. So.
We try.
Somebody told me that, and I'm kind of jumping over, but it could be something that you see. I was at Twin County Hall of Fame banquet the other night, and someone said there's a lot of human trafficking in our area. Is that something that you are made aware of at all through the clinic?
I am not. I can believe it, but I don't see it.
Well, and I believe this person, but it's something that I was really shocked, and it's really sad. And that's something that's under the radar, but I like our law enforcement here, so hopefully they'll be able to ferret it out.
I think one thing I will say is this: if you look at the statistics for, say, HIV and the rates of HIV per 10,000 population, Edgecombe County, which is, you think that's Tarboro, but it's really not. It's the eastern side of Rocky Mount.
Sure it is.
And Tarboro, but it's Edgecombe County is number 2 in the state of North Carolina.
For HIV infections.
For HIV. Wilson is like number 12, and Nash is like number 18. Well, what I think is if you kind of wrap all those three together, you sort of get the Rocky Mount, Wilson metropolitan area with I-95 running through it. So if that is a proxy for a lot of negative things, then we've got, it wouldn't surprise me with drugs, human trafficking and all that stuff. It wouldn't surprise me because we seem to have some markers for it. I don't see it there, but we do see, as I say, we've got 550 HIV positive patients. Not all of them are drug users, not all of them are, whatever, but if you use STDs as a proxy for demographic issues, then we probably do have a problem here on the 95 corridor.
Well, I'm glad we have that clinic, the Ryan White Clinic, because at least that helps make it less transmittable if they comply with the drug regimens.
Completely, and it changes those people's lives. They come in there, people know them, you get their medicine, they're encouraged, they're in and out the door, and there's a lot of hope and a lot of high spirits, and it's a good, it's the way medicine ought to be.
Let's talk a little bit about the vaccination acceptance rate in the population that you serve.
Yes. It's generally pretty strong.
Good.
It's generally pretty strong. We do have patients and people and staff that do not want to get vaccinated for one reason or another, and I think they have the information they need. I think it's just their personal decision that they don't want to.
It is a personal decision. A lot of people still think it's for religious reasons, even though everybody in the Vatican has to be vaccinated. Some people think that the vaccine was created from aborted fetuses, which is baloney. That's absolutely not true. And those facts need to come out to people. Some people have concerns about the messenger RNA, which we were talking about, and those differences of opinion need to be respected. But I still think we still need to encourage people to recognize the truths, and that is that people who are vaccinated have a significantly greater chance of living if infected than those who are not vaccinated.
You know, you can look at it a lot of different ways. My way was I got vaccinated, and I got the booster, and my wife got vaccinated. So I think our vote is to do it, and we're not certain that there are no complications from the vaccination. We certainly don't think there are. Nobody can be sure, but we're not certain what would happen if we got coronavirus. I mean, we're not certain how much the corporate responsibility is. In other words, for all of us to chip in to make immunity, you know, something that's that keeps the virus, puts it away. So I respect people's rights to not get the virus. I hate to lose staff because of mandates, but I certainly do encourage people to get it.
I sat next to somebody again at the Twin County Hall of Fame banquet, and she had it fairly early on, as did her husband. She has emphysema. That she knows absolutely, unequivocally, that it came from having COVID. And I know at Chapel Hill they're getting a long haulers clinic where they're working on brain fog and lung damage and heart damage and whatnot that people who had the illness had. And I want to live the rest of my life without brain fog or lung damage or something, and that's kind of...
And empirically, if it affects your taste and smell, it's by definition in your nervous system, because those are nervous organs. And we have examples of how chickenpox hides in our nervous system for decades and decades, and then surfaces as painful shingles when our immune system gets compromised. And this virus can very well hide in our nervous system and contribute to other diseases down the road. So you're right, there are problems that are unknown with the vaccine, but there are problems that are known with the virus.
Exactly.
And for almost 1 million Americans, they'll never know about those problems because they succumbed to it already. Well, that concludes our show tonight.
You want to tell about next time? Who's going to be on? Dr.
Dr. Wormsby, she's head of the surgery department at UNCPN Practice Network. An amazing surgeon, one of the new staff members.
She's head of surgery for that group.
And she'll be joining us to talk about the surgical experiences at Nash.
Good.
Okay. Thanks for joining us. Consider getting vaccinated. We'll see you in 2 weeks on Call the Doctor. And thank you, Jean.
Thank you.
And thank you, Dr. Brantley.
Thank you all for having me.
Sure.
Good night, everybody.